All right. I have another interesting case for your enjoyment. This is a 58-year-old male eval for abnormal test. That chief complaint can mean anything. More often than not, it means that the abnormal test was from a different hospital that you're not going to be able to find. This case comes from one of our friends, Ryan Debiek. And again, I'm handicapped with words. Anything that's beyond a 2-year-old to grasp, I cannot grasp. So I'm sorry, Ryan. Please forgive me. But you're not going to be mad at me because you're a nice guy. Because your name is Polish and Jewish origin. It's been theorized that the name means from the old Polish word Debek, meaning to befriend, to make friends. So you're my friend. Even though I can't pronounce your name, you're my friend. Or to become familiar with. Like I know Ryan, but I don't know him in the biblical sense, if you know what I'm saying. The name may have origins that the connotation of being a good neighbor. I mean, that's pretty apt. Like he's a good dude, good neighbor. He'll help you out no matter what. Like he'll give you a garden hose if your house is on fire. All right, so here's the case that he had. Again, evaluation of abnormal diagnostic tests, which can mean anything. History of present illness, 58-year-old female presenting with lower extremity wounds. Patient states he, was evaluated, defines ED earlier today for worsening wounds of the left lower extremity. Patient DPPT pulses were absent at previous ED with evidence of necrotic wounds. Vascular surgery was called and recommended transfer here for further evaluation and management. Patient states he has had revascularization of the lower extremity scheduled for the end of the month and recently had revascularization of the right lower extremity. Patient reports severe pain and numbness and tingling in the left lower leg, worse with elevation of the leg. Denies fevers, chills, nausea, vomiting, or abdominal pain. All right, so here's the EKG. I have nothing old to compare to, and again, I recommend you pause and work through your exercises. So here we are at the rhythm strip, lead 2. I do see 1P before every QRS. Okay, so it's sinus. The rate is fast, like 1, 2. It's definitely like over 100. Okay, so sinus tachycardia, up in 1, up in AVF, so normal access. For the intervals, like I definitely see a prolonged QTC. Like here's 1R, here's 1R. The T wave is definitely more than halfway between each one. And again, for the definitive QTC, I always rely on the machine. For the QRS, it is prolonged. Like it's definitely over 3 boxes. Okay, axis intervals. ST segments, let's see. So we have a complete left bundle branch block. So now we should use our terms for discoordinates and concordinates. I do see appropriate discoordinates in lead 1, as well as lead 3. Again, there's this repolarization abnormality or linearity or straightening of the ST segment that's definitely over half the amplitude of the QRS, which can be concerning, highly concerning. Same thing here, some discoordinates and this repolarization abnormality. Up here in AVR, everyone's going to be concerned to call this elevation AVR. It's not. It's appropriate discordance. Here in AVL, I don't see any discordance, but I do see flattening of the T wave. Here in AVF, slight discordance, again with straightening of the T wave greater than half the amplitude of the QRS, which always piques my interest. I do see appropriate discordance up here in lead 1. I do see a V1 bigger than V6, but again, this is a complete left bundle branch block, so you can't really apply that. I do see appropriate discordance in V2. Let's see what you see it on here. Here's the PR segment. Here's the J point. This amount of discordance, I mean, that's concerning for inappropriate discordance with the modified Smith criteria, or 1/4 of the amplitude. Okay. Over here, I do see appropriate discordance, and again, this linearity, appropriate discordance, linearity, appropriate discordance, linearity. So my overall interpretation is sinus tachycardia with a complete left bundle branch block and prolonged QTC with focal repolarization abnormalities, which could be concerning for acute coronary syndrome or occlusion. All right, so the patient, like we said, he's got a problem with an ischemic leg. Like he wasn't having chest pain, his troponins were not elevated. He was admitted to the hospital, and while he was on the floor, this happened. And here we have, classic torsades, or twisting around a point. Like look at like up, down, like torsades, like much torsades. Now, is this, polymorphic ventricular tachycardia? Again, doesn't really matter. Same thing, is this person stable or unstable? If they're unstable, you're going to shock them. If they're stable, you're going to reach for meds, specifically magnesium. Like he actually had a cardiac arrest, like arrested, They did CPR. They got him back after a while. He went to the cath lab. His coronary arteries were clean, but they did put in an AICD for him. And Ryan sent me this case because he's watched my previous videos and he remembers, the way I approach wide complex tachycardia. Okay, and this is important to go over again. Again, man, my kid is so popular. Wide complex tachycardia. For me, the rate has to be over 130. The Q restoration has to be less than 200. Again, this number here, it's not set in stone. Most people say like 130 to like 140. Okay, like it's not a hard cutoff. Like I've seen some people, elderly people with like classic VTAC, and the rate was like 125. And I've seen people where, it was more like a gap junction toxicity, and the rate was like 134. So they're not like hard set in stone numbers. They're just it's a general area. Okay. Remember, okay, so we have that because we have a wide complex with a rate over 130 and Q restoration over to less than 200. Then we go down our ventricular tachycardia pathway, and it's either monomorphic ventricular tachycardia or polymorphic ventricular tachycardia. Most common cause of monomorphic is structural heart disease. And for both monomorphic and polymorphic, we have like two subtypes. Okay. For monomorphic, the delineating thing is the time frame. More than 30 seconds is sustained monomorphic ventricular tachycardia. Less than 30 seconds is non-sustained monomorphic ventricular tachycardia. For polymorphic VTAC, it's ACS is the most common cause, and prolonged QTC is the most common cause. And again, in America, it's usually medications. If polymorphic VTAC with a normal, this should be QTC here. With a normal QTC is just regular polymorphic VTAC. Polymorphic VTAC with a prolonged QT is Torsades. Again, anyone who's unstable gets shocked, okay? And if they're stable, you reach for meds. The best one for sustained is procanamide. For non-sustained is beta blockers. For polymorphic VTAC with a normal QTC is amiodarone. For polymorphic VTAC with a prolonged QTC is magnesium. So that's, and also if you fall out here, like if you're like, I'm not sure it's VTAC because I'm not sure about that rate, I'm not sure about that Q restoration, then what you're looking at is an accelerated intraventricular rhythm. And the causes for that is either toxic, like drugs, many drugs, antipsychotics, anti-seizures, antidepressants, cocaine, meth. What's the other one? Methadone. Like there's so many that cause problems. Metabolic, it's either the potassium is high or the hydrogen ions are too high. And then there's connexin 43, like we talked about before, which is either like the heart or the brain. And see my other videos for that. So that's all I have for this case. I hope you enjoyed it. I am done now.